Hello and welcome to the latest episode of the Melbourne Athletic Development Podcast. Jack,
John.
today we were going to explore, after our recent discussion with Professor John Hawley, the concept relating to evolution of your professional practice. He briefly mentioned it and he spoke about the fact that it was probably more of an evolution rather than necessarily, significant changes that happened over time. And we thought it would be good to talk about how that evolution takes place and what kind of things seem to be, more prominent in our, clinical practice compared to maybe when we were younger clinicians.
Mm-hmm. Well, something that I think of straight away is how my perspective of the problem has changed. Because I think when I first began, you often think of the problem being very simplistic and thinking that there is a clear, absolute answer to solve the problem. And over time, realizing that there are a lot more layers that can be contributing to someone's problem. When I say problem, I'm really referring to, whether it's musculoskeletal pain or some type of musculoskeletal injury. And realizing that to find a good solution to that problem, you often need to think about things that influence not just understanding the diagnosis, for instance, or the actual interventions or assessments that you do, but then thinking about how you actually implement that into someone's life.
Yeah, well, we had something happen even this week. Like, we're having a team meeting. And as, we've implemented this process where we go through the new patients that come in and, make sure that our clinicians feel like they're going through their case and, navigating all of the areas. And we had one of our staff members start to go through it. And, like me being the pain in the ass that I am, said to them, like, all right, get to the point. Because they went on, and you laughed at me because I said, this isn't War and Peace or Crime and Punishment or something like that. And you're like, you're an idiot. But the point I was getting to was, it's important to know how to maintain what is important and what is not, and keep it succinct and related to the key things. And we always, I know it's something that gets spoken about a lot when it comes to, say, like sports performance, but like, keep the main thing the main thing.
Yeah. Actually, I was going to ask you then, because I feel like that almost is a contradiction to what I said, because what you're highlighting is you've got to be able to identify the signal from the noise. But part of that then too is what is the signal and what is the noise? Because something I was alluding to is, well, it's all well and good to, can it always be that clear? Can it always be that straightforward to be like, well, this is a problem, this is the way we're going to approach it?
I think one of the problems that younger clinicians have, and I think this is the difference as you get older, as you get good, not older, more experienced, you learn to discern when something is simple and when you do need to investigate further.
Yeah.
So, like, whilst it seems like on the surface that maybe we're kind of on different pages, it's not necessarily the case. I think, like, when you're younger, you don't, or I keep saying younger, I don't mean it in that way. I mean, maybe less clinically experienced. You tend to chase down rabbit holes that you don't need to. And it's really, really valuable, I believe, to know when further investigation is needed and when you're spending too much time looking at these things.
Yeah, actually, and that's probably a good thing to highlight, because I think of going back to university, we learn all about biopsychosocial model. Typically, though, we like to fixate on the biological elements. I want to understand what the specific diagnosis is. But then actually, you don't want to get too... This is where it's interesting to make that separation of, to begin with, you actually do want to understand specifically what the
issue is.
The issue is in terms of like the biological issue.
Yeah.
I'm not
What's
saying
the pathology? What injuries occurred?
Totally. And actually, if anything, perhaps that's one of the issues that's changed. Well, not issues, one of the things that's changed, where to begin with, you're a bit like, I need to get a bit of everything. I need to collect all the data. I need to collect this and this and this, because these will be related to it. Where nowadays, I know that that's relevant. I'm going to get to that. But to begin with, I want to go, what are you presenting with? What is the problem? And do I have a clear understanding of the source of the symptoms and getting an understanding of the severity of the pathology? Because that straight away gives you indications of where you go next.
And if something, I had this discussion with someone the other day, actually at the track, and I was saying, like using the principles of Occam's razor.
Mhm.
I think there's a big issue that happens, particularly in the development of a professional, and it very much comes out in the Dunning-Kruger effect,
Mm,
is you learn a little bit or you learn about a specific area and you start seeing confirmation bias where you start seeing that everywhere. And you want to apply that to everything. So you start retrofitting that into your situation. But as Occam's razor or Occam's principle suggests, is like that requires too many assumptions for that to actually occur.
mm,
If someone's walking down the street and they roll their ankle, stepping over a curve and a curb and they feel it, literally go into, this inversion
inversion.
type injury,
Yeah, yeah.
and then they can't walk on it. It's pretty clear what the mechanism, what the pathology is. At that point, there's no point saying like, oh, maybe there's some psychological component that's driving the development of their pain symptoms.
How does their cultural background influence their perception of the
And
experience?
it's not to say that it's not relevant.
Mm,
It is, because you will have people, for instance, who do roll their ankle where, and we've spoken about this before, certain cultures experience or demonstrate the experience of pain differently. Some people are very, flamboyant about it. And it tends to be, we've spoken about like the romantic countries versus
mm,
sometimes that separation. I think in Western culture, people from, Southern Europe versus Northern Europe.
mm,
Northern Europe tends to be very stoic,
mm,
so they roll their ankle and you can see them limping. And you're like, how's your ankle? Fine.
mm.
What's your pain? One. Right. And then you see someone who, from Southern Europe or they've come from that kind of region and they have a different relationship with pain. Not everyone, but as a generalization. And you see like they're walking around doing, cartwheels, and then you say, oh, how's your pain? Oh, it's 8 out of 10.
Mm.
Like, oh, your symptoms don't seem to, or, you're not walking in an antalgic manner. So,
Well, and I think the thing you're highlighting here is understanding that when do you need to apply different areas of knowledge and tying that into with the very simple thing of why do you think someone's actually come to see you?
hmm,
And I mean, I know that's something that we do with our online assessment of like, what are your expectations? And if their expectation is, I want to understand the problem or a diagnosis, then you need to make sure that you
spend some time
spend.
on that.
Now, I think that's a pretty clear and straightforward for most
From,
presentations
yeah, of
anyway.
course.
And the expectation then needs to be too of how do I go about navigating finding the best solution to this problem? Because typically in the first session, there's only so much time you have to collect data,
Yeah.
and there's only so many things that you can tell a patient or a client in one session too, without completely losing them in the process because you're talking about how their prior experiences
Or their prior
or
injuries
prior
and they're
injuries.
like, I've just rolled my ankle. Like, can you do something about this?
Exactly.
And that's where I think, as I said, as you start to develop more understanding, you get better at discerning when to dig a bit deeper, or you see a little bit of information that is relevant to keep exploring.
Well, yeah, go.
Rather than, and this comes down to like information gain. So I think we've spoken about this before, but someone like a Gerd Gigerenzer, who's done a lot of decision making research, for anyone
Mm,
who's interested, he's got some really cool stuff, and he's got a good book called Risk Savvy. But some of Gerd's work talks about difference of how explore information gathering,
yes.
and they talk about like bounded and unbounded, and rational versus irrational information. So bounded would be you keep it within certain parameters. And this is what we're talking about. You bind that into, I'm only going to look at the pathology, the tissue capacity. If you start opening up other areas of, and they're not that they're not relevant, but I'm going to look at some of the psychological and cultural and historical components to what's going on with this. I'm going to open up some understanding of their prior training history and their previous experiences and all these things. All of a sudden, that's become closer to unbounded. And then, you start going down the path of, rational versus irrational. And it's not that those mean like you're taking, you know, false information. It's you're actually trying to explore whether there are hard facts and objective things you can take, or more subjective things and how they, fit together. So
Mm.
understanding when to, be, using a much more bounded approach or an unbounded approach, I think you get better at discerning.
Yeah, and I think the thing that you highlight there is let's stick with the example of someone rolling their ankle, stepping on a curb. In that situation, what is the most important thing for you to decipher? And the biggest thing is really understanding, well, what do I think is going on and what is the severity of it? Because that's very much going to influence what you need to focus on in that session. I mean, for all you know, if it's severe enough and they can't walk, you
You might
might be
have a
thinking
fracture, yeah.
that they have a fracture. So, you may forfeit doing some things that might have been drilled into you of like, oh no, but do you have an understanding of their past medical history? What medications are they taking? What's their work? Like, these are things which
They're relevant, but in that
absolutely.
situation, you're actually
Well, you
not
have a
using the time to the most effect that
you
would get the best outcome for that patient at that time.
you have a time constraint, and the reality is, with work, you have constraints to realizing, look, I've got 20 minutes, half an hour, 40 minutes with this person. I have someone booked in next.
It's not even that, Jack. Like, I agree with you, and that is relevant, but it's not even that. If I'm the patient and I'm going to swear, but I fucked my ankle,
Yes.
I don't want to be sitting there spending 15 minutes talking about when I had shoulder surgery.
Mm,
At that point, I need your help. Like,
mm.
sort my ankle out.
Absolutely.
But like, you're actually doing me a disservice by asking me stupid fuck questions about my shoulder when it's pretty clear that I've hurt my ankle pretty badly and I
Mm.
need your help. I wouldn't be there otherwise.
No, no. Um, the other thing I was going to mention too that has changed a lot with the experience is you very quickly realize when you need to go, okay, there's actually something quite serious here. I need to rule out potentially a
Yeah,
fracture.
that's a really good point.
Because how quickly can you have that conversation of, within a couple of minutes going, okay, look, I actually think this is what's going on. I think we need to do the following things to confirm or refute this hypothesis.
Actually, and as I said, I think that you become clearer on, as you said, when you have to go a bit harder.
Hmm.
Like, and it's a really nice position to be in. Um, a lot of our, less experienced staff will come and ask us questions.
Mm.
And it's happened a couple of times recently, actually. We had one recently where um, the clinician did the right thing. They said, oh, look, can you see this patient for me? I've reviewed them. I believe there's something going on in their foot. Um, the diagnosis is this, but this is the differential, which was a little bit more serious.
Mm.
And I saw them and I said, oh, no, I think it's the more serious one.
Yeah,
They've got to
yeah.
get a scan now. They get the scan, it comes up, it's that. And they're like, oh, they were really good about it. They were like, oh, thank you so much for seeing him. And, like, they were on the right track. They'd made actually the right diagnostic kind of assessment. They just didn't necessarily have the fortitude to be like, no, go do it straight away.
Mm.
Right. And it's not to say that necessarily my decision making was better or worse. It's just I've seen it a few more times and I'm like, there's no point waiting to get this imaging done. I think it's pretty clear that something's going to come back.
Yeah, yeah. It's funny you say that. It makes me think of early on in my career where you'd see someone with what looks to be a very bad ankle inversion injury in the sense of visually it looks bad. There's a lot of
Oh,
swelling, a lot
yeah.
of bruising. And just by looking at it, you're like, oh my God, there's something really bad going on here. You've clearly got pathology. And it's like, oh, how you going? Like, I can walk around, like, put weight on it straight enough. Look, yeah, I could. But initially, I'd be like, no, you got to get your scan. There's got to be a fracture looking at how bad it is.
And
And then you start to realize, oh, wait, okay, that person, didn't have a fracture in this situation. And I mean, you've seen plenty too, where you look at an ankle and you go, that looks horrible,
yeah.
but it's actually okay.
And,
Well, I shouldn't say okay.
I, I,
There's no indications that they need to offload, for instance.
and this is part of that experience of developing your clinical knowledge and clinical skill set and this is very much exactly what they come to in the, Giga Renz's work of using heuristics,
Mm.
and a really simple one for the ankle becomes if someone, it doesn't matter how bad their ankle looks, if they walk in on it, there's probably not a fracture there,
No,
right? And it doesn't mean that it's always not the case.
of course.
There's obviously, you need to do the proper assessment, but if that's the case, the statistics, and obviously there's, the Ottawa ankle
Ankle rules, of
rules,
course,
which
yeah.
that is one of them. If someone can
Yeah.
take 4 steps, particularly immediately post the injury, then it's unlikely to be contributing, or the fracture contributing to the presentation. It's not the only rule, but it's some of this. I think there's 4. There's 4 rules, isn't there?
Yeah, there's one about palpation. Yeah.
We're testing our own memory here.
Oh, I wasn't going to go into the full details, but
No, you must, Jack. So the good thing is, once you start to gain something, you start to build up these heuristics that are like, and for people who don't know what a heuristic is, it's a rule of thumb. It's a basic decision-making tool that you can have. The the highest probability is that if you see this presentation, then it's probably in this category.
And we use heuristics in our everyday life. Like, this is something that helps us to be able to subconsciously navigate through every day, but it's something that certainly works it's very useful clinically as well.
On that, and this is a complete aside, so I apologize for hijacking, but it's funny how much cognitive dissonance you get when those heuristics fail, or something doesn't follow what you think it's going to do. It's just really funny stuff. And there's a lot, you realize how many things we take for granted because of those kind of, it's like, I would give a really dumb example of, like, in Australia, we use the basic heuristic: if the light's red, no one's going to come through that intersection.
Yeah.
Right? In other countries, it's probably different, but in Australia, we're really trusting. And I noticed this when I went overseas of like, oh crap, I actually need to be careful not to assume that basic decision that I make of, oh, the light's red, I can walk now, is not actually accurate in a different setting.
I know there's the exact same thing with zebra crossings in particular.
Yeah.
Like in Italy, I've noticed that if you start walking, the car's most likely going to slow down. But if you're waiting for them to slow down, don't expect them to.
No. It's very funny.
Like, if you're waiting, not crossing yet, thinking, oh yeah, I'll wait till they slow down, to basically indicate like, no, you've got right away. That doesn't necessarily happen.
Yeah,
but they will slow down if you start to walk. But you almost have to.
You have to initiate it.
Initiate it, exactly.
Yeah. So as an aside, but I think it's funny when you're like, it starts messing with you because you're like, I've got this idea of what's going to happen here, and it's just not necessarily the case.
And I think the other thing too that comes with experience is when you use heuristics, because I think subconsciously we fall to heuristics all the time, but also then when not to.
And that's the expert problem.
Correct.
That people talk about. And that in itself can be a big problem, because you're like, oh, I know what this is. So you start going down that pathway, as you said.
Yes.
And that can be so dangerous.
And look, I think just from my own experience clinically, where nowadays I probably see a lot more complex patients with, say, long-term pain.
Yeah.
Which typically fall into what you would call that more non-specific low back pain.
And I think that's, pain. As I said, for you, it's a little bit different.
Well, if it's different in the sense of, because I do still get people coming in. I had someone, for instance, yesterday where they came in, lateral foot pain associated with running. Straight away, I'm like, okay, this sounds like some type of cuboid syndrome type problem. That alarm, well, not that alarm, that form of thinking often doesn't happen a lot these days with the patients I see, because it's not so much about what's going on, but why. And I think this is where it's very important, and something that I think you improve on with clinical experience is when to make that transition of your decision-making process from the what to the why. Because we should be making that transition at some point, because you do want to have an understanding of the diagnosis. But there's always going to be that point when you're like, okay, we have an understanding what's going on. We know what specific management's needed early on if need be. Why did you get this problem in the first place? Now, sometimes it also may just be incidental, like someone takes out your knee playing sport and it's really out of your control. But the reality is, how many times do you see someone, and a good example is like a hamstring strain, where there's no external perturbation of going, why did you get an injury then? This is, and that's a very different process of thinking.
Yeah. Like, I think it's for you, it's probably interesting because I feel like you have, and this is just an aside, but you have evolved to be seeing a lot more of our complex presentations. I think definitely. You're sort of becoming the go-to person for that. So I feel like it's probably very different in that space, and you probably live in a world where it's like, I don't see very obvious mechanistic injuries very often, whereas I probably get a lot of those and you get the opposite. So this might be why you and I at the start were like, you're seeing this and I'm seeing that.
Well, it's funny actually. I think that has also been always a personal bias of mine, where, like, I studied physiotherapy, then I did a yoga apprenticeship. That's influenced my philosophy and kind of this very holistic view. But that also can be, well, I found that problematic early on because I'd often be like, well, what are the things that are relating to this? And then forgetting Occam's razor at times of going, let's just really focus to
Be like,
begin
what's
with
the
on
main thing?
what are they presenting with, and let's understand what the problem before we start to go to why have they've got that problem.
Mm.
So but now I probably attract more of an individual who it's much more important to have the knowledge and skill set to understand different variables and modulators to understand, well, you've seen someone else, you've got conventional treatment, you've seen a physio, a chiro, a doc, you haven't had a response, you've still got pain. Is there something that I can look at that hasn't been addressed yet?
And I think, yeah, I think it's for clinicians who are and practitioners maybe coming from the sports performance side of things too. Like I think at the start, maintaining the basics are really important.
Mm, mm,
You deviate away from that when you have the basics down pat. And I think one of the things that I've noticed with some clinicians and younger clinicians is they want to deviate away. And I'm not saying that I didn't do this, I'm sure I did this a lot, but you want to deviate away from the most obvious thing because it makes you feel like you're a bit more clever.
of course.
Like, oh, I looked at this and I looked at that. And it's like, yeah, well, that is, a quarter of a percent relevant. And the other 99.75% is like they just rolled their ankle and you need to address that pathology that's in front of you right there.
Exactly. Yeah. No. Like the reality is, when you're seeing, unless you're seeing a very nuanced population group, they fit into some pretty similar categories of what the actual
And
problem
that's where, yeah,
is.
those heuristics are important. I think one of the things, and it'd be good to talk to you because I had this experience in my coaching stuff a lot recently, and it would be good to ask you about this. I had this experience where I actually have had to heavily critique my own philosophy and approach to something.
Mm.
And I don't think there was a strategy behind that. I just kind of was like, I'm not happy with the result. I've got to actually explore this. How do you think you address that as a professional and as, whether it's um, a clinician or in more sports performance of like, I keep seeing this trend of, these patients aren't getting better or I
Mm,
keep getting
mm.
this result. Maybe the way I'm approaching this is not the right, solution for that. Do you think that there's a process you can go through to actually arrive at that? Or is it just about, being open-minded and questioning yourself?
I think there's both. In short, I actually think that's where it's really important to be able to have other people that you can
Yeah.
communicate it
Yep.
with, because well, I know I spend so much time in my own head in general. I guess we all do, and that's the same with patients, particularly the ones who you haven't had the outcome that you expected. But the issue that is when you're trying to reason it yourself, you still have our own
Well, I guess
bias.
John spoke about this, didn't he?
Yeah, well, it did absolutely.
I think this is why, like, whether we like it or not, we tend to be attracted to people who think similarly to us, have similar experiences, and generally have a similar worldview.
Mm,
Right? And I don't say that in any critical way, but we tend to be comfortable in those settings. So even for us in a professional setting, and people will probably do this, you tend to probably professionally align with people who have similar philosophies to you. Now, they might differ in some areas, but the general premises are the same. Like if someone, I'm going to use it again, we use the ankle example, it's just to keep it simple, but like if, for instance, the philosophy of your clinic is, okay, you get them to start loading that from early on and they're walking and doing all of those things, you're probably not going to have too many um, clashes with people. You're not going to have too many clashes compared to if you had two clinicians, one who's, I always put them on crutches, even if they can walk,
mm,
versus, no, we always mobilize them as soon as possible.
mm.
I feel like if you had that in your clinical setting, and you had a robust professional environment, you'd be clashing, going like, no, you need to get them moving, and the other person would be like, no, you need time to let that heal and not put any loading through it. And there's different reasons why people might have those different philosophies, but we tend to be attracted into environments that
Yeah.
are more homogenous in their thinking.
Yeah, look, I agree. But at the same time, too, I think about, say, when we have weekly meetings to discuss new patients. The thing that I think is really valuable about us doing it as a group is the questions that we ask the clinician about that patient do vary. Like I think about
Yeah.
when even recently when we had a meeting and we had one of our colleagues talking about a new patient, the questions that you asked to related to, like, well, do you have a clear understanding of the diagnosis? Have you looked at this? Have you looked at that? Versus the suggestions I gave versus the suggestions of one of our other
Hmm.
colleagues do vary, and I think that is where the real value is because there's no doubting that there are times when you say something or someone else says something. I'm like, oh, actually, that's a good point. Like,
I
that
think
wasn't my default to go to that, but
the
it
the
actually is
reason I say that
covered.
is, well, I think one of the things that we're lucky with, and it's by design. Like the thing that we pride ourselves on is exploring information. It's why we do the podcast, why we talk to people, and actually having some diversity in how we think.
Mm,
Because people talk about diversity a lot, and it can happen exactly as John said by going into different countries, getting different cultural experiences, different knowledge. But it actually can just come with people having different experiences and having different ideas,
yeah,
and not we spoke about it with John, but like not getting upset if someone has a different idea to you. I think one of the things that we pride ourselves on in a lot of ways in this setting, and it doesn't always work, and it's not always perfect because we probably do at some level try and keep some level of homogeneity, but
yeah, yeah.
we actually appreciate that you do things a little bit different to me, who does it different to some of our other clinicians, and we have different ideas, and we actually value that rather than
Yeah.
saying, no, you need to do it the way that we always do it, and I do it this way, so you've got to do what I do. And that, I think, is important.
And I think the thing that's important to remember is health can be sustained or health, or I mean like recovering from pain or an injury can be done many ways. There's many ways you can skin a cat. So the thing that we always have to realize is if you have a good outcome with someone, their pain's alleviated, they get back to playing sport, whatever their outcome is, that obviously starts to create a positive confirmation bias to us of like, great, what I did is really good. The thing that we need to be able to explore better is you've seen a similar patient who rolled their ankle. I saw a patient who rolled their ankle. You and I might do slightly different things. And it's actually, that's where you sort of be like, okay, like John did this, I did that. Now we kind of had similar outcome. Is there something I can take away from that? Because otherwise you're still stuck in your own echo chamber of going, well, no, I had a really good outcome. And it's interesting. I remember, she's going back to when I started as a graduate, clinical Pilates was the absolute thing to do,
Yeah,
and it's still pretty strong. But
uh, it's
then
it's something that people were really investing a lot of time and effort into.
the reality is we are all susceptible to certain fads and trends, and at that point, clinical
It
Pilates was
was
the
really
thing to do.
exploding. Yeah,
And I'm not suggesting that it doesn't have value by any means, but I
I think that's
remember,
what you suggested. Yeah.
but I remember talking to a colleague where I was arguing about, look, I don't think it's useful for this and that, and the person said, well, why does it work? And I didn't say this at the time, but reflecting on it is the question I don't necessarily think we need to ask ourselves all the time is, will it work or not? But is that the optimal strategy to do?
Well,
And
I think that's a really good example of why you need to be able to go to the next level of analysis,
mm,
right? Because if someone says, why does it work? Right, and it's not that it doesn't, like, it does work, and it works for a very specific reason, right?
yes,
And this is where I think as you get more experience, you start to ask the question, okay, as you said, why does this work? Or
mm,
why does this not work?
and well, I was going to emphasize the latter
Hmm.
because again, it comes back to there's many ways you can skin a cat. You could do clinical Pilates for low back pain, and they start to feel changes in their symptoms over time. The issue then, of course, is the whole correlation versus causation.
But
But
like, let's use that example because I think that that's the right example.
mm,
The reason that it works, if you go to that deeper level, what is Pilates?
mm,
Well, it is a level of resistance training that's typically low force and low velocity,
mm,
requires stabilization of multiple areas of the body, maybe in some sort of coordinated fashion, maybe in a more isolated fashion, right? But if you look at it, for someone with back pain, particularly if they are not extremely active, or they're not doing a task that requires higher velocity and higher force tasks, that actually may be the requirement that they need in their tissue of their spine and surrounding areas to be able to navigate the biomechanical stresses that they experience.
And to just extend on that, for the general population, that also may be the first type of physical activity that
And
they're
resistance,
participating in.
even though from people who have done higher levels of resistance training, that may be a very low stimulus, particularly in the level of force.
Yes.
For someone who hasn't been doing anything, as you just mentioned, that might actually be quite strenuous for them, right? And so for that reason, it causes adaptation to their muscle tissue and to their neurological systems and has a positive outcome.
And even more acutely too, we can start to see changes in their immune system function by
Yeah,
getting a muscle to contract,
that's the stuff that Rob Newton spoke about,
understanding
obviously.
that it's metabolically active. It'll influence the inflammatory process, and if you're working the back muscles and you've got back pain, all of a sudden you start to change the overall inflammatory status and therefore the peripheral sensitization.
Exactly. So when you understand that, you say, oh, okay, Pilates can work if it's the right level of stimulus for the right patient, right? And we don't necessarily do what I would consider classical Pilates exercises, but we do a lot of low force,
We're applying the principles.
low velocity resistance training
Totally.
for people who have back pain.
And this is
We
where
do that. We do that every single day in this clinic, right?
yeah.
And yes, it's not going to be, if you looked at it, you wouldn't go, oh, that's a Pilates exercise. But it very much could be, right? And it fits very much into that category. So to say that it's useful or not useful is probably misinterpreting what it is.
And this is where you need to then start to think about what is the resolution of thinking and reflection that you need to have, because the reality is lots of health professionals who do lots of different types of interventions, some of which we might consider to be very questionable, may have quote unquote good outcomes. So that in itself is relatively low resolution to think about, should I be doing this or not? Don't get me wrong, obviously having a good outcome is a very valuable thing and something that is we should be thinking about. But understanding the why then too helps you to be able to be more nuanced about, even if you apply that
When you
intervention,
apply it, yeah.
how do I configure those variables differently? And then, as you mentioned before, and this is where I think the big learning process comes too, of going, when it doesn't work, why? Because to suggest that one thing actually always has a good outcome is just flat out incorrect.
I think, and as I said, I had this issue recently, and it still is. I'm navigating it at the moment. It's a really difficult process to go through where you've been philosophically aligned with an approach. You teach someone how to do something a certain way, or you approach an injury in a certain way, or for me, it's, I coach a certain aspect of the running in a certain manner, but it's actually not getting the result. And so you either have to start questioning your capability of teaching that, or applying it. Like a dumb example on this, and this is an aside again, but people go, oh, manual therapy doesn't work. It's like, well, maybe you're just shit at manual therapy, right? Because some people claim that it does a hell of a lot of good, and I would say they're probably right.
And look, the first thing you have to ask yourself is, that's a relatively low resolution statement and question to ask.
But it's the same thing as I said that I'm talking about from the coaching. It's like either manual therapy doesn't work or you don't work, right? And you have to ask yourself that question. And after teaching something in a certain way for a long time, I'm like, I don't think that I haven't necessarily evolved my understanding to teach it well enough. Maybe what I'm actually applying needs to evolve, needs to change. And I think there's a lot of challenge in that, in the sense of you get worried about lost time and lost effort. But at the same time, I think, personally, I'm philosophically more aligned with getting a good result than I am with, maintaining me being right, which makes it easier. Because the funny thing is, and I can ask you about this because it happened a little bit with the athletes where I was like, look, we're going to do it this way from now on. And they were like, what the fuck? You've been teaching it this way for 3 years, 4 years. Like, why are we changing? I'm like, it's not working, right? And I had to say, some of them were like, yeah, but I'm like, oh, okay, do you want to run faster or do you want to hold on to something that's not working?
Mm.
And they're like, run faster. I was like, well, then let go of it. And I think it's the same thing that happens often with patients. Like, patients will sometimes realize, and I think you and I are similar, like, we don't really care what we do as long as we're getting the outcome for the patient,
Absolutely.
right? But sometimes patients will pick up on that. Like, last time you said we're going to approach it like this, and this time we've almost done a 180 on that.
Mm.
And you're like, yeah, well, that wasn't working. So
Mm.
what would you rather? Me say that I was wrong and I need to change it? Or would you rather me stick to it and say, I'm right,
Mm.
you're just not doing it properly? Or, you know, clearly something else is happening. It's like, no, maybe just what you're applying is not the right thing for that individual.
Mm. Yeah, no, absolutely. I've had a couple of patients in that scenario myself recently.
Yeah, and it's a weird situation to be in at times because you actually have to explain to them, like, what we applied was not the right intervention,
Mm.
right? It's not because that intervention doesn't work. It's like what you were saying before about, say, with Pilates. With the right person, it works perfect. With the wrong person, it might not work at all. It might make their back pain worse,
Mm.
right? And there's talk about this. We spoke with Georgie, who was on our podcast. She's got some interest in women's health physio. And one of the big things that's become a massive area for them is this evolution of people having pelvic floors that are overactive
Mm.
rather than underactive. So
Mm.
at the start, when people talked about women's health physio, it was just like, oh, you need to train your pelvic floor, it needs to get stronger, it needs to do these contractions and hold and do, these Kegel
Contracting throughout the
exercises.
day, and yeah.
And then what they realized is for some people that was increasing their, problems. They were getting more discomfort, they were getting more symptoms. And I'm like, wait a minute.
Well, and the
Maybe
more
the problem's not they need more, it's they need less.
and the more nuanced experience of it was helping, but now it's not.
Oh,
And
that is a good situation. Can you maybe elaborate on that more? Because
well,
that's so true.
well, and like, it makes you even think about, say, with you reflecting on your coaching and say changing a particular approach to whatever element it is. Maybe it was working actually for a period of time for certain athletes, but now based on the evolution of that athlete, you actually have to then change your mindset.
And I think that's a really, really, we spoke about this actually
Mm.
recently when we spoke. We're referring to a lot of other podcasts, so maybe go listen to them if you get a chance. But we spoke about that when we talked about like sprint approaches of how like what worked in the past may not work in the future because that person has evolved. And that happens a lot
Mm.
where I think it happens both in clinical settings and in coaching settings where
Oh, for sure.
what got you to here is not the thing that will take you the next step.
Mm.
And if you've aligned yourself with that approach at a philosophical level, I approach all back injuries with Pilates.
Mm.
It's like, okay, well, that's great, but this person has come in there a different presentation, and you need to evolve beyond having that as the only approach that you take.
Or
And
the funny thing, or the patient who comes in, they're like, "But I've been doing Pilates for 5 years."
it's like,
Yeah.
oh yeah, that's thrown that in the bin.
Yeah, yeah, and it hasn't really changed.
And
Oh, no, no, it's because we need to do this particular
and
style,
that's and that's exactly where I think you have what I mentioned before, where clinicians start to play that stupid game where they go, no, no, it's because I'm the expert on
Mm.
applying that. And it's like, well, maybe you are, but maybe actually that's not the approach. And
Mm.
so that approach for this person is not relevant. Doesn't mean it can't be applied.
Yeah,
But
of course.
it's the problem that we've spoken about a lot in relation to protocols, right? So like, I think one of the, and this is probably the next topic, but one of the things that I think happens over time as well is you become much more individualized,
Mm.
right? You go from taking a template, a protocol that has the right principles in mind, but over time you realize, no, I actually need to approach this with this individual in mind.
Mm.
And the reason that you do that is not actually because there's anything wrong with that approach, other than over time you notice that you don't end up getting the results that you want.
Mm.
And when I say you want, the patient doesn't get the results. They're like, oh, I've still got back pain. And you're like, oh, but we went through the protocol all the way to the end. That's like, okay, well, that's not addressing what we needed to, obviously.
Mm. Mm. I mean, the other thing I think with that too is that is that the depth of your thinking to follow just a protocol as well? And I mean, that sounds maybe harsh in a way, but it's something I often think about too when you want to be able to pride yourself on having certain knowledge and expertise. To simply just be able to go verbatim, this is what I'm going to get you to do, I don't think is really giving yourself much credit from what you may know,
Mm.
let alone actually optimizing the outcome for the patient because they come to see you hoping to be able to get an expert, nuanced approach.
It's funny you say that, actually. You have some patients who don't necessarily see that.
Mm,
I've had a few issues with people recently where I'm like, I would like to see you, more regularly, because I would like to not necessarily fast track, but I would like to make in real time changes to what we're
mm,
doing. And
mm,
they're like, nah, like I can just do this, at, my rehab at the gym. You're like, okay, fair enough. If
mm.
you think that, that's fine. Like it's probably a failure on my ability to, communicate that.
Yeah, I think that's actually, going back to the start of this conversation about how you navigate what you do with a patient and understanding the what, moving to the why. That's when I think you probably start to think a bit more broadly about, okay, what are certain psychological, emotional attributes about this person that are going to influence
Yeah.
how I actually plan? Because that's something that's really big. And like, I know an example yesterday, I had a patient who um, is a quite a good athlete, does a lot of physical activity, developed some overuse pain, did some manual therapy, felt a lot better. And then I said to this person, like, look, obviously your symptoms are a lot better. I think the thing we need to really look at here is trying to actually start to implement some other types of training modalities because you're just focusing on one particular training modality, you're overloading your tissue, you're getting symptoms. Let's catch up next week and actually look at some tissue capacity measures and start to think about what we can do from that standpoint. And then I noticed that they, didn't book in again. Now, it's not because they didn't value the service. This person's seen me plenty of times before for other issues, but they come in going, "Look, I've got pain. I want you to get me out of pain so I can go back to training full time." And part of that is, okay, I'm trying to educate the person. I want to try and help them out to be able to prolong the next time they actually get another issue. But for them, they clearly go, "No, we've done 3 sessions. I feel fine. I'm leaving it at that."
Hmm.
And this is where, you start to understand certain personality profiles. And I mean, that can be something as simple as, again, something that we try to collect data on is like, how long do you think this is going to take? Or like, how much, are you able to come in? Because some people have some pretty set parameters about that. And some people have different expectations, I think, too. Like, I know it's something we've talked about before, but I think typically more middle age, older people are much more responsive and open to going like, look, these are the things we need to work on, and they go, "Yep, I put trust in you as a professional to help guide me through that and give me the best recommendations." I think more and more you see with younger people, it's like, I can just do that myself. And it's not about whether you can or can't do it by yourself because, I mean, I know you're the same. A lot of the time it's like, look, these are the things I want you to do
Mm.
independently.
Yeah.
The reason why I want you to come in is not so you can just do it again. The reason why you come in is so I can actually do some reassessment and progress the program and get you in at, instead of 7 days, get you in at 3 days so we can actually progress them more quickly.
Mm.
But again, some people have this idea of like, no, no, once a week's enough. And this is where I think it's very useful to think about how you collect information about some of those psychological profiles and belief systems because they're such a big influencer for what someone's going to do next.
And it's funny because I think that when you're less experienced, you don't necessarily think about that. You kind of just like whoever comes through is who comes through. But
Mm,
you start to identify those things early on. And I
mm,
think you become a lot clearer with the communication that you have around that. It's like, as you said, the number of times more recently, they're like it's funny because I think that often they feel very confronted when you it's like,
yeah.
look, clearly you say to them like, I'm sensing that this is an issue for you. Is that the case? And they're like, what? And
Mm,
you're like, I'd like to see you for this reason.
mm,
Can you make that happen? And they're like, oh, that's like really direct. And it's
mm,
like, it's not because I'm trying to be forthright. It's just because you're pushing back, maybe subconsciously, and I think it's not going to help your outcome.
mm,
You've told me you want to get a good outcome and you want that to happen in a timely fashion. And now you're pushing back on me. And I think that that's something that when you're less experienced, you are less willing to kind of address, or maybe you don't even recognize, like, oh, I made this recommendation, they didn't follow it, right? And they haven't got the outcome, and now, like, I'm having to explain to them they didn't follow the recommendation. Whereas I think as you get more experience, you kind of say from the start, like, this is the recommendation. You don't follow this, and the probability is that you won't get the outcome you want. So just be aware of that before we even start.
Yeah. Actually, I'd be interested to hear your thoughts on this, because the other thing that has changed a lot with how I approach communicating with a patient is, let's go back to the ankle inversion injury. Person comes in, rolled my ankle. I want to get back to running, but it's really painful. Like, I need to get the pain under control. If you look at it and you go, look, it's probably going to take you 6 weeks. And they go, 6 weeks? Like, that's so long. Now, in your head, you might be thinking, it's going to take 6 weeks between now and discharge.
Yeah.
But, we're going to spend the next 10 to 14 days focusing on getting your pain under control so you can walk normally. You'll probably be running back in
3 or 4
3
weeks,
weeks,
yeah.
But it's so interesting, and something that I've certainly been more nuanced about is the information you feed someone. Going like, okay, you really want to get a pain reduction? The next 7 to 10 days, we're going to be focusing on getting your pain down. And I expect that you'll be able to walk pain-free within 10 days.
Yeah, I think
Okay, great.
communication that develops. Because, I think when you're less experienced, you have probably less understanding of what the probability of that is.
This is true.
So
Yes.
that makes, I think that is one of the nicer things, is as you've seen things more, you have a general understanding of, okay, it's probable you'll be walking relatively pain-free in 10 days.
Yeah. And again, shout out to previous podcasts we've done, but that concept of uncertainty and how we deal with that, because the reality is people have an expectation of giving certainty when they come in to see you.
One thing you made me think of there, which I think is actually relevant, is, and it does go into this more unbounded kind of areas, is I've actually asked a few people a few times why it's such an issue if they don't, especially in non-competitive athletic populations, right? And I've had this answer come back a few times, which is someone will be like, they're like, oh, when can I get back to training? And they train for recreational purposes, whether it's running or whether it's, gym or CrossFit or something like that. And they'll go, 3 weeks, like I can't, like I can't not train for 3 weeks. And I've actually said to a few people, like, what's your issue with not training for 3 weeks? And you realize that for some of them, it's mental health management. And it's good these days because people are much more willing to talk about these things. People will say, oh, it's like, it's how I manage my mental health. And I've actually gone to the effort of saying, like, okay, well, what other things can we do and what can we put in place so that you feel like you are still, if exercise is the thing that you want to maintain, how can we do? And then it often is a very easy fix. It's like, oh, I normally run. It's like, okay, well, are you happy to cycle for this 2 or 3 weeks while we're getting you back to running? Oh, yeah, I'm happy to ride. It's like, okay, well, let's just ride. And then, oh, okay, yeah, no, it's all right. I'm not as worried or anxious about the fact that it's going to take 3 weeks. And that's something that I think in the past I just would have glossed over in some ways, and because I was not aware to even ask that question or wouldn't have even thought to prompt that.
Well, and that actually makes me think of something else that's changed a lot since I first started working. Is one, you start to perceive yourself as much more as a professional, and therefore, when you speak to someone, I very much see it as I'm giving them my professional opinion. It's not a personal thing. It's not me going like, this is my personal bias and perception of you. It's like, my professional recommendation or my professional advice is this. Take or leave it, and part of that is also a negotiating process of going like, that doesn't suit me. Well, how about I meet you here? Okay, that's all right. I'll agree to that plan. But not, I mean, you still obviously have an emotional reaction when you don't get a good outcome or someone doesn't come back, but less and less so. I mean, part of it is, again, going through that same reflective process of going, I didn't have an outcome that I wanted. What were the deficits or limitations to that? But it's something that certainly has changed a lot, where you start to be able to remove so much of the emotional, personal elements to people that you engage with professionally.
Yeah, it's funny you say that. I remember as a younger clinician, I was actually working in aged care at the time. And my boss at the time called me in and said, "Oh, look, we've got this feedback from um, from one of the patients that they would prefer if you aren't the person that sees them." And I remember being so annoyed about it, and my boss being like, "What's the issue?" And I was like, you know, my professional conduct is part of my like it's who I see myself as, and blah blah blah. And he was like, "Mate, you cannot, you need to learn how to separate this." And I was like, "Fuck off, no I don't." And I was like, now looking back, and I was like, gee, I had a long way to go because it wasn't helpful for me to, and not that there isn't intertwining of your personal and professional conduct, but it wasn't helpful in any way. Like, I actually needed to understand that not everyone is going to like your professional approach.
No.
As long as you conduct yourself in a professional manner, and you're giving the advice to the best of your ability, and it fits within the recommendations that are reasonable, then you need to accept not everyone will take that on board, and they may not want to use your services, even though that what the recommendations you've given them are very useful.
Well, look, I think of actually too, I'm sure you probably had a similar experience of patients I've ended up referring on to one of our other physios in the clinic, because I don't think actually you and I are gelling as well as we could, or you've actually got more of this type of personality profile. You actually probably be better with this person. And in fact, I've seen really good outcomes because of it. And like, there are times when you go like, yeah, you know what? Maybe you and I aren't the best people to gel with, and particularly too with some long term patients.
Yeah.
Someone like following an ACL reconstruction, I can think of, who I referred on to one of our other physios, and I think probably had a better outcome because of it.
Yeah.
Just because of differences in personality, and that's okay. Like, I don't think that's necessarily a bad thing. And the reality is, the kind of patients that we attract, particularly when it's word of mouth, are going to be within a certain type of profile because of our own particular philosophies, in addition to how we interact and communicate.
Yeah. Alrighty, Jack. I think we've covered off on a hell of a lot of things there, but if there ever is anything that people want to discuss or want us to discuss, or share some of our experiences, feel free to contact us via our website, or on any of our social media channels. Thank you for listening.
Thank you. All right.
Oh, we got 50 minutes out of that.